All right, good morning. My name's Jan Schoenberger. I come to you from Los Angeles. I work at Los Angeles County USC Medical Center. I'm the residency director there for our 68 residents. And I'm very happy to be here with you. We're going to have a break right after this talk. So this is our last talk of the morning before that 15-minute break. And we're going to talk about TIAs. And this is on page 153 in your Bible. Your Bible for the next 4 days. Okay. This is kind of a tricky topic, and I think a lot of people feel very frustrated with TIAs, often because they're managed in lots of different ways, depending on who you call. And maybe one of your questions is kind of what is the evidence and about how to manage these TIAs, and do I have a better sense of what I need to do? So what exactly is a TIA? The definition of this has changed over the years. Right now, the definition is kind of tied in with imaging, because that's where we are in 2017. A TIA is really a transient episode of some kind of neurologic dysfunction. It's caused by focal, brain, spinal cord, or retinal ischemia that is negative basically on imaging. And in 2009, the American Heart Association, in conjunction with the American Stroke Association, changed the definition of TIA that really came from the evolution of the workups that we're doing and the increasing use of advanced imaging. So they said that basically TIAs, which are neurosymptoms that clear completely but are later found to have ischemic changes when you do an MRI, those aren't TIAs, those are strokes. And so things that we used to call TIA, not knowing what the imaging showed on the MRI, now sometimes those fit in the box of strokes if their MRI actually shows some kind of ischemic change. So what's in the box of TIA and what's in the box of stroke changed in 2009 with this new definition. And so as you read the literature, you have to keep that change in mind as the definition changed. Abstract number 1 is a paper that really kind of illustrates this. This comes out of Penn, and it has this nice little phrase in it, which they call the Will Rogers effect. And what that means is that Will Rogers, who was this comedian, once said that when the Okies left Oklahoma and moved to California, they raised the average intelligence in both states. And how that applies to something diagnostic and clinical is that if you change the diagnostic criteria and it appears to improve the prognosis in the two conditions, well, that's kind of the Will Rogers effect. And so in Abstract 1, these authors tried to basically put some numbers to the change of this effect. And so they looked at strokes and TIAs based on 2010 census data and AHA statistics, American Heart Statistics, and published literature. They basically said, using this new definition, if you change the definition, well, then basically your annual increase of ischemic stroke is going to go up, because now what we used to call TIAs, some of the people in that box are now going to be called strokes. So the incidence of that's going to go up. And strokes are going to look a lot better, because those ones that moved over to now be called stroke, which we used to call TIA, are pretty minor strokes that have very mild or no disability. So strokes look better. And over here, what you're left with the TIAs is probably your lower risk TIAs in general as well. So by changing the definition, you really made both groups look better. And that's important to keep in mind. So they put some numbers on this. The numbers aren't that important, but they kind of illustrate that through this census data. And so they just say it all looks better at this point, and that's important to know. So are TIAs still important and something we need to take seriously? Well, of course. We know that about 15% of people who go on to have an ischemic stroke have a TIA at some point before that stroke. So we know that it's a warning sign of a stroke for some people. And in addition, we know that there's a short-term risk and we know that there's a longer-term risk. So what are those numbers? A lot of this data came out of the Northern California Kaiser system, and they found that TIAs that go on to stroke in about 2 days, that risk is somewhere around 5%. Plus or minus a couple percentage points, somewhere around 5% in the first couple days. And if you go out to about a week, it starts to creep up towards 10%, and as you get to 90 days, you start to really get to about 10%. Abstract number 2 kind of goes over this. This is a review article from Nurses Sanosian, who's a really nice and smart neurologist that I work with at USC, and he published this in 2009, and he basically looked at data and made this point about this risk rate, and that the risk of a CVA is somewhere in the 2 to 10% range in that first week, depending on a bunch of variables. And these variables we know. These are the things that are in the ABCD2 score. This is age, this is blood pressure, this is the clinical presentation, the duration of their symptoms. All of those things matter in terms of what the risk is, what that number will be for the patient in front of you. And so in this paper, they suggest you need to look for modifiable variables. You have to address those things that we know make a patient higher risk, like your blood pressure, like the diabetes, et cetera. And you should start with some advanced imaging, and we'll talk more about advanced imaging and what information that can offer you. But it can help identify for you people people who are at higher risk, people who have vascular issues, for example. You should lower the blood pressure, you should consider starting an antiplatelet agent, all of those kinds of things. So the next question is, can we accurately diagnose a TIA? This is one of our most challenging clinical dilemmas. The patient comes in, they've got some kind of transient neurologic symptom. Am I going to call that a TIA or am I not going to call that a TIA? And how do I separate those out? And really, the bottom line is that your clinical judgment is really the best thing you have going for you. We know that even when it comes to stroke, there's a lot of mimics out there. And the same is true for TIA. It's no different in terms of mimics. We know from papers that up to a third of patients that we call strokes turn out to ultimately have a diagnosis of something else, some kind of mimic, whether it be a migraine, whether it be a psychogenic cause of that neurologic symptom, whether it be syncope, whether it be some kind of peripheral vestibular disorder. There's a lot of things on the list, a seizure, for example. There's a lot of things on the list for mimics for stroke, and the same is true for TIAs. The same is true for TIAs. So we know that that's a risk. And that's a particularly scary risk when we're talking about giving someone a squirt of TPA, for example, theoretically, and we know that there's a significant bleed risk to that. So we're caught in this dilemma. We know there's a lot of mimics out there. On the other hand, we have this treatment that we're being pushed to give that has a real downside to it. And that is where we're kind of caught right now. So how can I tell? What does the paper say about this mimic thing? So abstract number 3 is from 2011. It's a British study looking at clinical scores for identifying stroke and TIA in the ED, and they looked at these scales to see how we perform. They looked at 2 different scales. The Rosier scale, which is basically called recognition of stroke in the ER. It's a scale that we don't use as often. And the FAST scale, which we're probably a little more familiar with, which is face, arm, and speech test. And so they basically looked at how ED docs and nurses measured patients on these different scales. They looked at over 350 patients presenting with a suspected stroke. They looked at how they scored on these different scales. And the gold standard was basically a consensus diagnosis of stroke or TIA by a blinded expert panel who then went back and looked at that chart. And it turned out that a third, just like the number I told you, about a third were judged to have stroke mimics. What were those mimics? Migraine headache, focal seizures, sepsis was even on the list, peripheral neuropathy, vestibular issues. And these scales performed pretty poorly in picking those things out of the bunch. And the numbers, again, are not very good. The sensitivities are in the 80s, the specificities in the 30s and 40% range, not very good. And clinical assessment and judgment was basically just as good as any of those scales. So abstract number 4 is another paper about stroke and TIA mimics and how frequent they are. This is Swiss authors this time, looking at 300 patients presenting with a presumed TIA, and they aim to assess the frequency and characteristics of TIA mimics, those mimics. And in their group, it was 18% that were ultimately diagnosed with mimics, seizures and migraines being at the top of the list. They followed those patients that were determined to have mimics over 3 months to see what their stroke risk was. Maybe it's just as high. Maybe we have to be just as worried. Of course, it wasn't that high. Of course, we weren't as worried about them. It turns out that they followed those patients for 3 months. In the stroke mimic group, none of them had a stroke or MI or death, while in the real TIA group, the ones that were judged not to have mimics, 14% of that group did. So if you could sort those out, there really would be a bigger risk if it was a real TIA. Oh, and the ABCD score, just to throw that in, it looked about the same in both groups, Whether you had a mimic or a real TIA, the ABCD score did not help really differentiate those 2 groups. They did note in this paper, kind of interestingly, that the odds ratio for a mimic went up when the patient had things like memory loss, headache, blurred vision, some more of the atypical symptoms, and it went down and made a mimic less likely when they had unilateral paresis. That was like a real thing that put them more in the TIA category. Abstract number 5 comes from the US. It eventually kind of comes up with the same conclusion. This is out of Rush. They reviewed the data for 100 patients who were diagnosed with TIA in the ED to determine the rates of misdiagnosis and predictors of mimics. The final diagnosis was TIA, where they basically attributed those symptoms to a vascular territory in only 40%, meaning that 60% did not meet that definition. So what were the mimics in this group? Again, same list: seizures, migraines, toxic metabolic conditions, neuropathies, psych. They tried to slice and dice their data to determine predictors. I don't think there's much you can count on there, but again, it just shows you that people are hard to categorize. Now, abstract number 6, it might be a piece of good news. We don't really know yet. This is a British group. This is February 2016. They're trying to come up with maybe a new score that's better than what we have right now. This is called the Diagnosis of TIA score, or the DOT score. And And they basically designed and validated their own score. This hasn't been externally validated yet, so it's not ready for prime time, but just to show you that there are people out there working on this. They had about 900 TIA clinic referrals for their derivation set, and they had a little over 500 for their validation cohort. And basically what their DOTS screens, what their tool is a set of 17 questions. So it's not straightforward and simple, but it's 17 questions that goes through the things that we know help us predict who really has a TIA and who's at high risk. Age, hypertension, AFib, a bunch of clinical findings on that list of 17 things, and you basically answer like a yes, no to each one of them, and then it gives you a score, and it risk stratifies, probably TIA, possibly TIA, unlikely TIA, and they say the sensitivity and specificity of their score, the sensitivity is in the 93% range and the specificity is in the 70% range, which would be, if it were true, better than what we have right now, but again, has not been externally validated. So it's not ready for prime time, but you can Google it, you could do the calculation if you want to play with it. Now, at the next page, we see the ABCD2 score, which is really the best thing we have out there right now. And unfortunately, I'm going to cast a gray shadow over it, but that's what a lot of us use to help look at the TIA patient in front of us to determine at how much risk is this person at. Are they in the high-risk category or not in the high-risk category? And so you see there's age, there's blood pressure, clinical features, duration of symptoms, diabetes, and the risk of CVA at 2 days is listed there for the ABCD2 score. So does this really work? Does it help risk stratify people with TIA? Because we know that not everyone that has some kind of transient neural feature is going to go on and have a stroke. We certainly want to find those people. Can we predict? We don't think that this works very well. And one of the things that we're going to get to at the end of the chapter is an ACEP clinical policy that just came out in September 2016 that's going to tell you, just a preview, not to rely on this score. But basically, here's the next 4 papers looking at it. The news isn't very good. Abstract number 7 comes from Dr. Perry in the Canadian Medical Journal. This is 2011. They did a validation study of the performance of the ABCD2 score, just over 2,000 adults, 8 different Canadian EDs. All these patients have a TIA or minor stroke. And in terms of how often stroke developed, they had stroke develop in 2 days in 1.8% of their cohort, and within 90 days at 3.2%. So this is a pretty low risk group that they're looking at. About double that had a recurrent TIA. And when they looked at the ABCD2 scores that the docs calculated, they were somewhat lower than the scores that were calculated by chart reviewers. So they did have some sort of external look at the ABCD2 score. They looked at different score cutoffs. If you move the score cutoff around, would that maybe help in terms of the sensitivity and specificity? And the bottom line is it didn't work very well. If you move the cutoff score to a higher range, like a 5, the sensitivity is only 31%, but you raise the specificity, right? If you move it lower, then you get the opposite effect. So they concluded that it's not really a reliable tool for assessing the risk of stroke. Now, abstract 8 is from the Annals of Emergency Medicine. It's from their evidence-based EM series that they do. This is from 2013. They have a synopsis of a meta-analysis that was published about the performance of the ABCD2 score. 16,000 adults here in this meta-analysis. They also concluded that the performance is suboptimal. The sensitivities are pretty high, again, if you change the cutoff, but the specificity is just horrible. So again, not very good. Abstract number 9 comes from Japan. They basically they're trying to modify the ABCD2 score, and they want to throw in another D. They want it to be ABCD3 instead of ABCD2. This is in 2014. They suggest that basically D should be dual TIA, meaning that if you have a recurrent TIA within 7 days, that you would have a higher risk. And they also want to throw in an I, which is for imaging, showing that if you have carotid stenosis big time, or you have on your CTA some kind of major carotid stenosis, that would be also helpful in terms of predicting who's at high risk. Throw in the imaging factor there. They looked at its performance in almost 700 patients. They thought it performed a bit better in predicting stroke, but this has also not been externally validated outside of this Japanese group. And they even say in their abstract, you should not use this to make clinical decisions. We're just suggesting that this might be where we're going in terms of predicting who's at higher risk. Abstract number 10 is the last of these looking at this. It's an Italian study comparing the utility of the ABCD2 score to unenhanced head CT, non-con head CT, plus a carotid Doppler done within 24 hours of presentation. Again, kind of throwing in the imaging factor in almost 200 patients. And they basically said the ABCD2 score alone didn't perform very well, but if you throw in the imaging, it seemed to make it a little bit better, kind of like the Japanese study. So has imaging been of much help with these new techniques and having more expertise and we're throwing in lots more MRIs, MRAs, CTAs, is this making a difference? And abstract number 11 tries to answer this question a bit. This abstract is from 2012. They retrospectively looked back at imaging in 160 patients with ischemic lesions who had CT scans followed within 24 hours by an MRI, and they looked at 54 patients who only got MRI. Needless to say, over 95% of the CTs were normal. We know that. The non-con head CT that we get up at the beginning is basically meant to rule out a bleed and maybe rule out something else that could be significant that might be causing the symptoms, but it's not going to tell us much about the risk of that person in front of us in terms of going on to have a stroke. It doesn't give us that information, so we know it's not that helpful. It's just there to rule out a few other things. So of these, over 95% of the CTs were normal. Only 4% suggested a possible acute infarction. MRI was way better, confirmed an acute infarction in 2 of the 7 patients where CT suggested it. And it found an acute infarction in a third of those patients who had initially a normal CT. A third of those patients who initially had a normal CT. So they basically say this should probably be first-line imaging, and in some places it is. How many of you, if you have a person that you think has a TIA in front of you, are ordering an MRI in the ED, doing an MRI? So some hands, not many. A minority of us are going to MRI as almost like first-line therapy, but that's kind of where we're going because of this definition that's changed, et cetera. It's not standard of care yet. I'm just suggesting that that's really what some of this stuff is telling us, is that we need to go to the advanced imaging a little bit sooner in our workup. We'll look at the ACEP clinical policy and talk about what it says about imaging in a little bit. So the next question is, where should we send patients with TIA? Oh boy, if I were to survey all of you and say, how many of you send the person with a TIA diagnosis home? How many send them to an OBS unit? How many of you admit them? We would see answers all over the place. And it may even be where you work in your system, that people with TIA even do different things within your own hospital, get admitted different places depending on who you call. And that is kind of the standard of where we are right now. At a minimum, in terms of what we do for that patient in front of us in the ED of our workup, what are the things that we do? Most of us would get an EKG. I think we could agree that that's something we're going to get. A non-con head CT would be reasonable to get if you have that available to you. Then do you push yourself, or some of you going, you're going to do some basic labs. Okay, we'll give our stat. We're going to check a glucose. We're going to do some basic labs. But then we start thinking about neck imaging. We start thinking about, echo and those advanced things that they need. And then it starts to come down to systems issues. Like, how are you going to get that stuff done for this patient? And in what time frame does it need to get done? And that is a question mark in terms of what time frame it needs to get done. We know that some of these patients are going to be at higher risk in the next couple days. So most recommendations would be to get those things done in the next 48 hours. But there's no evidence to suggest that that improves outcomes for everybody. It's just about trying to risk stratify, right? That's why we get those tests. So this next abstract, number 13, is kind of a Canadian paper talking about having a rapid diagnostic protocol or putting people in an OBS unit potentially. Abstract 13, but abstract number 12 sort of outlines this Canadian approach in terms of rapid access to a clinic or a day unit and trying to expedite the workup. But again, this is in the Canadian system, not in our system. We'll talk a little bit more about rapid diagnostic approaches. Let's move on to abstract 13. This is a recent paper. This is from just last year, April 2016. This is New England Journal, so it's a big one. And the title is 1 Year Risk of Stroke After TIA or Minor Stroke. So not just TIA, so it's TIA or minor stroke. This was a big international prospective cohort study from 21 countries with dedicated stroke systems so they could get a quick assessment and treatment. They had almost 4,600 patients with TIAs. 90% of these patients were seen within 24 hours. They were all seen within 7 days. And the plan in this cohort, and the study is still ongoing, is to follow this big cohort for up to 5 years to look at basically a composite outcome of badness. Do they have big strokes, non-fatal heart attacks, et cetera? So kind of recharacterizing this population in today's day and age of workups as to how high risk this diagnosis is. This paper is just the 1 year report of the data. They're planning to look at it at 5 years, but at the 1 year mark, 70% of the patients in this cohort had no disability after the event, did just fine. And just to give you an idea of whether or not these were really TIAs, that means that 30% had some kind of disability. So if 70% did okay, that means a third of them didn't. Median hospital stay was 4 days. Stroke was documented on imaging in a third of them. 1 in 20, about 5%, had new onset AFib, so that's something we definitely look for. 2/3 of those ended up getting anticoagulated. They also found that 16% of them had carotid stenosis, over 50%, so some had neck lesions, and 1/4 of those got revascularized, so they were treating them pretty aggressively. So in that 1-year outcome, how many of you do you think that they had the really bad outcome of a big stroke or an MI? It was 6.2%. So in terms of stroke alone as an outcome, in the first 7 days after the index event, 2% had a stroke, and it was about 5% at 1 year. And it did tend to increase with a higher ABCD2 score. They actually did see some prediction of higher risk with using the score. It was up to 10% if you had a score of 7. So the last thing to mention here before we talk about the ACEP clinical policy is antiplatelet therapy. Should you use aspirin alone? If you're going to start something, should you use aspirin alone or combination antiplatelet therapy? So aspirin plus a Plavix, for example. And that's abstract 14, 15, and 16. I'm not going to go through the details of each one of those. There's a lot of numbers in there. But the bottom line there is that aspirin and Plavix, the combination therapy, is probably a little bit better, but carries with it more risk of bleeding with the combination therapy. But in people who are really high risk, if they don't have contraindications or things that you worry about in terms of bleeding, it's probably a little bit better based on the data, not a whole lot better. You have to kind of make that decision in terms of who's in front of you and what their risk factors are for bleeding. So those are kind of what the abstracts say. Abstract 16 is a meta-analysis of 14 RCTs. And they did say that dual therapy seemed to be a little bit better, but certainly the risk is a little bit more with dual therapy. So abstract number 17, our last abstract, is the published version of the ACEP clinical policy that was just updating. We have to know what our professional societies say that we should be doing. This is often used as standard of care, and so we need to kind of know what they say. And they really addressed 4 questions in this clinical policy. The first one was, can you rely upon clinical decision rules, like the ABCD2 score? Can we use that to predict who's higher risk for stroke that we have to be more aggressive with, for example? And the answer is no. They don't tell you what to rely on, but they say that that's really looked in terms of looking at the evidence. It's not something that you can rely on. Should you still use it? Is it reasonable to use it and use it in your documentation? Sure. But in terms of relying upon that solely, the clinical policy says you can't rely on that solely. Number 2, what imaging can safely be delayed from the initial ED workup? This is a huge question. And basically the answer is level C evidence, which is not very good. And the fact is we don't really know. What they say is that if non-contrast MRI is not readily available, head CT will do, implying that if you had the MRI readily available, that's probably what you should be doing, although they don't explicitly say that. But they basically say that MRI is, basically that head CT will do, but if MRI is not readily available, fine, you can do a CT. They basically say it will help identify some of the TIA mimics, like a bleed, like a mass lesion, but that you can't use that CT to help classify who's at higher short-term risk for low or high risk for stroke. And they say that when feasible, physicians should be getting diffusion-weighted MRI to identify patients at high short-term risk for stroke. And when feasible, you should also be getting vascular imaging of the neck. It can be carotid ultrasound, it can be CTA, it can be MRA. Any of those things are fine, but looking at that as a risk factor would be important. Number 3 is, can carotid ultrasound be used instead of CTA or MRA to look for severe carotid stenosis? And the answer, level C evidence, is yes. You can use those things. So if you're doing a CT or a CTA or an MR and MRA, you can use that data to classify basically looking at your carotid arteries. And then last is, can a rapid ED diagnostic protocol be used to safely evaluate TIA patients without high-risk conditions? Could you put them, for example, in an OBS unit and do the rapid diagnostic protocol for patients who are not super high risk? And the answer is yes. It's a level B recommendation. If you don't have someone who has an abnormal initial head CT, these are the high-risk things, a suspected embolic source, like they have AFib, they have cardiomyopathy, they have a valve problem, some reason that they really probably had an ischemic event, they have known carotid stenosis, they've had a big stroke before, they're having crescendo TIA symptoms, all of those things would be very high risk and put them in a different category. They should be admitted. But if they don't have those high risk things, you could do a rapid diagnostic protocol to evaluate patients who are at short-term risk for stroke. And they actually, in the clinical policy, give sort of a little diagram and a suggested diagnostic algorithm about how you would put somebody through this rapid ED diagnostic protocol. And on that list of things that you should be doing includes, for example, example, a neuro consult or a cardiology consult for some patients. I mean, it's not exactly the kind of thing you would do in the ED. You'd have to have a place to kind of do this and give some time to get all that stuff done, but they give you an idea of what papers have said that should be in that rapid diagnostic protocol. It's things like serial clinical exams, telemetry, advanced imaging, echo for some people if it's indicated, neuro or cards consult for some people if it's indicated, and initiating antiplatelet therapy. That would be what they mean as a rapid ED-based diagnostic protocol. That's what they're talking about. So just to wind it up, some summary here, and this could be sort of frustrating, I think, at the end of this chapter. The take-home is difficult, because what am I telling you? I'm telling you that TIA is something that puts people at higher risk for stroke. Definitely at the 2-day mark, we're somewhere in the single digits. At the 1-week mark, we're getting closer to 10%. At 3 months, we're definitely at about 10%. It's a high-risk thing. How do I know who's high risk? I just told you that the ABCD2 score isn't very good based on the evidence. That's true. It's probably the best thing we have right now. It's still a reasonable thing to use, but the ACEP clinical policy says you shouldn't rely on it, and that's what you have to know. In addition, we have to know that our diagnosis of TIA isn't perfect. There are going to be people who have mimics. We know this from the evidence. This is true for strokes as well, and it's going to be hard to tell. And so doing a good H&P is really important, and doing your best, using your clinical judgment, knowing that it's as good as any of the other scores that are out there is something that should empower you to feel confident in your diagnosis of TIA. Most people in the USA are getting some kind of expedited workup. How that happens in the system where you work is going to be all over the place. And that's where we are right now in 2017. Some people are doing MRIs in the ED. Some people are referring them out. Some people are putting them in the OBS unit. Some people are admitting them. That's kind of where we are. And the purpose of doing all those things is to try to modify risk factors. The whole purpose of a TIA workup is to look for things that we can modify, bringing down their blood pressure. If they have a big carotid stenosis, maybe we refer them to do something about that. If they have AFib, considering anticoagulation, looking for all the things that we could do to prevent the stroke in some people is what all of that workup is about. Exactly when that workup has to be completed by, there is no official guideline on that. We just know that some people in that group are going to be at higher risk in the short term, and we're just trying to find those the best that we can in the systems that we work in. ACEP has a new policy on TIA. I think it's important to know that. We just went through the basic things. It says you can't rely on clinical decision instruments to decide who you're going to discharge in terms of who's not at high risk, because they're not great, so you're going to have to make a clinical decision. In terms of imaging, we know for sure that non-con head CT is not going to be great. It's kind of what most of us are left with as a first-line test. That's okay. It's going to rule out some people in terms of having mimics, but really in terms of advanced imaging, MRI would be better, and diffusion weighting imaging even better, and looking at the neck vessels is something they're going to need at least in the first little bit. I can't tell you exactly when that is. It depends on what you have access to. As long as patients don't have really high-risk conditions, the people that you should admit for sure are people who have AFib, people who have big strokes before, people who are having crescendo symptoms, people who have valve issues or cardiomyopathies who need an expedited echo. Those are people that you want to admit. Knowing that those are high-risk people is an important thing to know. And that can be done from an OBS unit if you have one, or you're going to admit them. So it depends on what you have access to. And that's the end of TIAs. We'll go into our break. I'm here for questions if you have them, and we'll see you for the panel after the break.